Hi, I'm Brian Mandel, the editor-in-chief of the Cleveland Clinic Journal of Medicine, CCJM. Welcome to Beyond the Pages, CCJM podcast, where we will take you in depth into the content of selected articles from the Cleveland Clinic Journal of Medicine and explore a few interesting tangents along the way. Through moderated interviews with our authors and other experts in the field, we hope the clinicians will gain a more nuanced perspective of clinical concepts that are changing the practice of medicine and be able to apply this perspective to the care of our patients.
Welcome back to part 2 of our conversation. Please be sure to listen to part 1 of this episode. Let's get back beyond the pages. Now, going through your articles, I was pretty shocked by talking about the different surgical interventions that are available, and a lot of it involved lasers and high temperature water spa things happening. And I was really well, it sounds like science fiction. So can you kind of walk us through some of these techniques and maybe give us some scenarios where one technique may be better than another for an individual patient?
I'll start in the office. You want to start in the operating room?
Sure.
All right. So we'll start with the MISTs, or the minimally invasive surgical therapies. That term was coined a few years back when all these things started to come about. These really exploded over the last decade, and in large part that was with some very good direct-to-consumer advertising. The ability to preserve ejaculation and treat BPH in men, that caught a lot of people's attention. So some of the earliest treatments that we had in this category were the prostatic urethral lift, which its brand name is the UroLift. And what that is, it's like curtain ties. So the little loops that you have in the curtains that are hanging on the wall at home, you tie those little loops to the hook on the wall and they hold the curtains back. That is essentially what the prostatic urethral lift is for the prostate. It's done in the office or in an ambulatory center. You come in with a little sedation, go in with a scope, and you put these tacks in, so to speak, in the corners of the prostate to hold it open. That works for mild to moderately enlarged prostates. It does not work well for prostates that have a median lobe. It does not work well for prostates that have a really high or tight bladder neck, so that bladder-prostate junction, because you can't really put the tie into that ring of muscle to hold it open. So that's sort of the first one that really took off. That was then followed up by Resume, or water vapor ablation, which is an in-office or, again, ambulatory surgery center procedure. That one, you use steam to essentially cook the prostate. So back to that watermelon analogy, a little needle comes out of the scope, you put it into the pink fruit of the watermelon, the steam percolates out through the tissue. There's a natural barrier, which we refer to as the surgical capsule, between the pink fruit and the white rind of the watermelon. The steam doesn't cross that. So it actually just stays confined within the transitional zone, the part that grows with age, kills those cells, and then over the next 1 to 2 months after the treatment, the body reabsorbs those dead prostate cells. You wind up with a nice big open channel. And this treatment, there's probably about a 90% chance that men will keep their ejaculation. The UroLift, or the prostatic urethral lift, the one I mentioned first, that one is essentially 100% ejaculatory sparing. The caveat to that one, though, is you're just moving tissue, pulling it open. You're not really eliminating any tissue. So that's where water vapor thermal therapy really moved up to another level, is because it's clearing tissue out. Granted, patients have to have a catheter for a short time because the prostate swells up initially after you inject a bunch of steam into it.
Yeah.
Just kind of makes sense. Otherwise, there's a whole lot of emerging treatments that are coming out, which are intraprostatic devices. So the iTind, which is the temporary inserted nitinol device, that device is for the small prostate with the tight bladder neck. And interesting story, it was developed from the wire cage on top of a champagne bottle. That's where the inventor got the idea from. He was sitting with that wire cage looking at it one day and kind of said, you know what, I bet we could make something like this to pop open inside a prostate.
Wow, okay, that's how inventions happen, I guess. All right.
So, it may be some other factors there stimulating the patient too. The iTind is kind of cool. You put it in, it stays in for about a week, and it uses pressure necrosis to push down and open up that bladder-prostate junction. So for a small, tight prostate, it's really nice. It's an outpatient solution to what used to be a transurethral incision of the prostate, which was done surgically and carried a little bit of a higher risk of retrograde ejaculation, loss of ejaculation. So that iodine treatment might be nice for folks really looking to preserve fertility, a smaller, more obstructive prostate, which may be more common in younger guys. It might be in that family, starting age range. Other than that, other office-based treatments are really, being looked into now. Include some things that are really more in the developmental pipeline. There's a lot of clinical trials on other prostatic stents and implants, some of which are intended to be permanent, some of which are temporary. There's another one that came out recently. It's the balloon dilation of the prostate. And that was something that was done historically years back, and it showed a temporary benefit or maybe even a placebo benefit if you read the research studies on it. It's also something that sounds like it's commonly done in nursing homes nowadays when patients step on their catheters or pull them out. All jokes aside, though, this new treatment called Optilume, they've taken the prostatic dilation balloon and coated it with paclitaxel. So what it does is it splits open the top of the prostate, the anterior commissure, deposits the paclitaxel there, and then prevents those lobes from growing back together. So again, similar to some of the other treatments, you're not really removing tissue, you're just rearranging or moving it, opening it so that the urine can flow more easily. That intervention has some pretty good 2-year data so far looking at the clinical trials on it. So we anticipate that one's probably going to gain some traction as time goes by.
So quick question, in terms of like how patients do, like how much, like I just imagine, shooting hot steam into the prostate. What does it feel like the next day, like after the procedure?
That's a great question. So I counsel my patients with all BPH procedures to essentially expect similar, irritative symptoms with recovery. Anything you do to the prostate, anything you do to the base of the bladder, that bladder-prostate junction, that's the neural epicenter of the bladder. And the way the body's going to register that is, oh, I have to pee. Oh, and by the way, I have to pee right now. So urgency is going to be very common after any kind of prostate intervention. Frequency, there's usually a little bit of hematuria, some pink or red coloration in the urine that you can expect. But then all of that really settles out and kind of passes, the first few weeks after the procedure. Usually by a couple weeks out, most folks are back to urinating a little bit more on a regular basis, less urgency, less frequency. And then again, as time goes by, they get out more to that 1 month, 2 month point after procedure. That's really where you start to see the big benefits.
So that was the in-office procedures?
Yes.
So now we're going to move on to the surgical?
Sure. So
the surgical room? Or,
the operating room, the OR.
Sorry, I'm a rheumatologist. I blew it.
Oh,
OR.
no worries. So I think before we start talking about the operating room procedures, it's good to keep Dr. Gill's analogy of the watermelon in mind, because for all these procedures, we're going to directly remove the red meat, or I guess the red of the watermelon, the red part of it. So we can start by talking about TURP. And so, this is the classic procedure that's still the gold standard for all other BPH procedures. And the way it works is you have a resectoscope, which is a metal tube with a hollow inside that you can put a cutting loop through, an electrified loop. So we navigate our way into the prostatic urethra, and we're going to use that loop to scrape or resect parts of the prostate out to open up that channel and make it bigger. And so that's typically how that works.
How long of a procedure does that take?
So I would say it depends on the size of the prostate, and I think that's really appropriate for a moderate size prostate. We're talking 80 grams and below. I think on average, probably an hour to hour and a half to do the TURP procedure. Sometimes less, depending on the size and the expertise of the surgeon doing it, but an hour is good average. So, that's the gold standard, and it's really withstood the test of time with showing that it has durable results.
So what does that look like years or what, like?
I think studies have shown that people, if you do a really thorough resection, can have good results up to 10 years and still not need another surgery, right? I think that's...
Yeah, we talk about, for instance, photovaporization of the prostate or the green light procedure. When I was in residency, we did a study looking at durability of that. and it was probably about a 10% retreatment rate at 10 years. And exactly as was mentioned, it's all about how neurotic the urologist is and how much of that pink fruit of the watermelon they chase down and clean out. So if it's a better clean out, it's going to last much longer. And we'll get to simple prostatectomy and some of the enucleative procedures like HoLEP and those things here in a bit, but that's really what came out of that study too, is studies where procedures where more tissue was cleaned out tended to fare better in terms of durability and a lower retreatment rate, whether it be for medications, for BPH, or for a secondary intervention, follow-up procedure.
So, and then we can move on to PVP, which you just alluded to. So PVP stands for photovaporization of the prostate, and we're using a laser fiber that...
The laser. Then we're getting
yes,
the laser.
it's a laser, exactly. It's a laser, and it's actually a side fire laser. So, imagine it going straight like this. The laser fires out on the sides, and you can rotate it. But so essentially that laser works at 532 nanometers, which is the wavelength that hemoglobin absorbs. And so it's kind of focusing on targeting all the blood cells that are within the prostate. And so the way it works is it actually vaporizes prostate tissue. So with TURP and other approaches, we're taking these like long slices, and usually have these chips that, you push into the bladder and we have to take out afterwards. But with this, you're literally vaporizing it into nothing. So you do that, you do vaporize at 360 degrees and really open up that channel. And PVP is really great for patients who maybe can't come off anticoagulation, because as we're saying, we're vaporizing hemoglobin, so it's very hemostatic. It's great for those sort of patients. I would say PVP is also probably best suited for people with moderate sized prostates, 80 grams or less. You can do up to 100, 120, but it's probably better for moderately sized prostates. And then another one to discuss would be HoLEP, which is you're also using a laser. And so HoLEP stands for, it's actually like describing the laser type, holmium enucleation of the prostate. There's also thulium laser, but HoLEP is the most popular form. And so with this, you're actually using an end fire laser, not a side fire, but an end fire. And with this, you're using this laser fiber to actually, I'm trying to figure out the best way to describe it. Imagine you're kind of going in and starting from the edges of the watermelon, and you're peeling off that pink fruit. Like you're trying to, peel it in block in one piece or in multiple pieces, but you're kind of like peeling it and resetting it off in block, and you want to leave the white part of which is the capsule, the rind of it behind. And so that's how HoLEP works. And because you're leaving the rind behind, you're leaving all the nerves of erection and things like that.
I changed my fruit analogy for the HoLEP.
Oh, you did?
So for HoLEP, I go to the
orange peel?
Yes, the orange. So it's like sliding your finger underneath an orange peel. You go in with the scope, you make a little cut, and then you actually use the scope to physically peel out the fruit of the orange and then kind of plunk it into the bladder. And then you come in with a morcellator and basically grind up the tissue, evacuate it out of the bladder from there. But yeah, there's a lot of cool things we can do with lasers.
Yeah, that sounds like creative uses of lasers here. Okay.
Yeah, the green light's my favorite. It's like a science fiction movie.
Yeah, so it's actually green.
Yeah.
Is it? Okay.
And you have to wear these goggles that filter green light.
Wow, it's actually goggles.
Yeah, you have to wear it.
It feels pretty special.
Yeah, it's intense. But the laser, you see it hits the tissue, and the heme molecule just absorbs that energy, and it causes the water in the cells to boil. So it literally turns into bubbles. The laser hits the tissue, it turns into bubbles, and they just wash away through the fluid that irrigates through the scope. So it's like a science fiction movie.
Sounds like it.
Yeah, it's pretty cool.
Yeah, I like PVP as well. All right. And then we can talk about simple prostatectomy. So this used to be done with an open approach, suprapubic incision, but now we're doing it robotically. And so here the idea is you have 5 or so small laparoscopic port incisions that are made across the abdomen. We bring the robot in, and we're actually able to go in, we'll drop the bladder down, find the prostate, incise just the anterior part of the prostate, and actually go in. And instead of using our fingers in the old days, we use the robot to really scoop out the inner part, which I guess is the orange, if we're going to use the orange analogy, and kind of get all the meat of the orange out of it and scoop it out robotically. And so it's really nice because we only have to make small port-situs incisions. There's no big incision, so oftentimes patients can go home either the same day or the next day with the Foley catheter for about a week. It's a nice, minimally invasive surgery that's good for really big prostates. So I would say HoLEP and robotic simple are good for larger size prostates. And then another advantage of the simple prostatectomy is that if someone has like a diverticulum or other, like, even a large bladder stone, it's a good option as well to kind of tackle both things at once.
How does it, can you explain that a little bit?
Yeah, so if someone has a large diverticulum, which is an outpouching of the bladder, when we go in to remove the orange peel, we can also resect that because we can see the bladder right there. We're going to drop the bladder, we can resect that and close up the bladder. So we could address that. With someone with a large bladder stone, where we can make an incision, look in the bladder and literally take it out, and remove it through one of our, extend one of our incisions and pull out that stone as well. So unless you do kind of two birds with one stone.
So who would be a good, so that's kind of the ideal person for a prostatectomy?
Larger prostate.
Larger prostate, and they have like could also have
other comorbid conditions such as a bladder stone.
Even without the other, concomitant pathology, the simple prostatectomy is still a really nice approach for big prostates. The bladder diverticula, I described to patients as a weak spot on an inner tube, which that analogy is kind of lost on most of our trainees nowadays. I don't know, how many folks are familiar with the inner tube inside of a tire and, going down a snowy hill or floating down a river on it. But that little outpouching in itself can cause symptoms like BPH. So you have urine that yo-yos back and forth between a diverticulum and the bladder. Somebody comes in to pee. If they're obstructed, they have to generate a really high pressure to push the urine out through the prostate because it's enlarged. That pressure can cause a weak spot to develop in the bladder. And then when they urinate, the bladder squeezes, pushes some urine into that diverticulum, that outpouching. Maybe they empty out a little bit of urine through the urethra. But then when they're done urinating, things relax. The urine basically falls back into the bladder out of the diverticulum. So you can wind up with very poor bladder emptying in those situations. It's always important to take care of the obstruction first when you have that case, whether it be going in and doing a scope procedure. Sometimes you may not even need to do the diverticulum. It might just, if it's not very big, kind of not worsen, and as long as you can reduce their emptying pressure by opening the prostate, it might just take care of itself. But other times, if that diverticulum is very large, then you go in, you essentially just remove it from the bladder and sew up where it was. And doing a simple prostatectomy is a very nice way to do that, because it's a one-stop, take care of everything. And that can be open or robotic. So, back to those 1889 articles I mentioned, the more sort of updated evolution of that was something called the Millen procedure. And that was done or really described in a big series in 1945 in London. And that's a procedure where you just use a small incision above the pubic bone, and you essentially go down right through the top of the prostate. So think about just making a cut in an orange and putting your finger and scooping the fruit out. It literally is that. The downside to that, though, is blood loss is usually a few hundred ml if you're fast.
Okay.
A little bit more if you're not. But the robot has given us the ability to do that literally same exact operation with blood loss on the order of 1 to 200 mLs. So it's a much less physiologically stressful procedure for the patient. And with some of the newest robotic technology, the single port robot, you can actually do this procedure with one single incision near the belly button, and those patients go home the same day and have gotten their catheters out as soon as 3 days after surgery. So, what historically was maybe way back when in the 1940s and 50s, a 1 week or longer hospitalization, is now an in and out same day procedure, and it can even be done with spinal anesthesia.
Wow, that's incredible. I mean, the amount of options available is just kind of amazing to me to hear what people, so many different approaches for, different pathology and different sizes and different problems for the patients. That's really impressive.
Yeah, so another procedure that's sort of emerged and was just added to the BPH guidelines is PAE, or prostatic artery embolization. And so it's sort of this, I guess to describe it, so it's done by interventional radiologists. And what they do is that they go in and do their angiography or encapsulate those vessels, and they actually find the vessels that are feeding the prostate. And so then they can embolize it with glue or coils and kind of deprives that prostate of its blood supply. And so then it's now going to be ischemic and want to go necrosis, and that can improve BPH symptoms. We don't have a lot of long-term data on that, but it is, it's now added and it's approved. I think in general, it's really nice for patients who aren't good surgical candidates. They can't just tolerate anesthesia for their comorbidities or other reasons, or people that can't come off anticoagulation. That's another good option. And another indication would be patients who have like refractory bleeding from the prostate. This could be another good option to address that. But
so I guess we could imagine that, with the watermelon analogy, be able to like isolate the vessels to the green part versus the red part to some degree, or is there some ejaculation issues with or erection issues with that one?
It's going to restrict blood flow to both parts of it.
Both parts of it.
All of it, yeah.
Okay.
And then that will cause the red part to shrink and the green part as well, but mostly the red part.
Yeah, the rates of erectile dysfunction, de novo erectile dysfunction after prostate artery embolization don't appear to be tremendously high in the literature, but a lot of the data that's out there is retrospective, so we don't really know a whole lot about the procedure. It's an evolving approach to managing large prostates. It definitely has a place for certain cases. It's a very, very nice option for folks that may be unable to tolerate anesthesia, that need a little bit more than what an office-based procedure can provide them. Like some of the other procedures, in particular the water vapor ablation, it's not the fastest in terms of result because you have to wait for that prostate to essentially atrophy with the lack of blood supply. So there may be some prolonged time with a catheter afterwards until a really big prostate can shrink down some. But it definitely fills a niche need for BPH treatment, and that's really why the American Urological Association guidelines evolved to incorporate that in the most recent revision. One of the other newer procedures on the BPH guidelines is aquablation. And we're going to get back to robots here, but the robotic water jet ablation. This is, think of it as a pressure washer for your prostate. So a really, really high pressure, very precisely controlled water beam, similar to a CNC machine for those that are familiar with manufacturing or engineering. But
all right.
You use a transrectal ultrasound to map out the inner portion of the prostate, that pink fruit in the watermelon, and program the robot to control the water jet to go through and essentially just wash out all of that pink fruit that's in the watermelon. And one of the neat things that they've been able to do with this procedure is to preserve the zone around the ejaculatory ducts. So you can treat a pretty large prostate with this and fairly routinely preserve ejaculation. One of the caveats, though, is it's bloody, as is any prostate procedure. So what they do after they do the robotic part is they go in with TURP loop. So the old kind of standard of prostate surgery, they go in with a TURP loop and clean up the resection bed from where the water jet worked. So they have to scrape off some slough tissue. They have to burn bleeding areas, coagulate the bleeding areas, to be able to do this as an efficient or same-day procedure. But it in a way has, from a lot of people's perspectives, democratized the approach to bigger prostates. HOLEP, for instance, the holmium laser enucleation, or THULEP, or BiPolEP, take your pick. There's all these different scope procedures where you can enucleate, where you can peel that orange out, have very, very steep learning curves, and can present, with risks of stress incontinence and strictures and other problems like that may be more common when someone's in their learning curve. But what's been shown with the robotic water jet is that it seems like something people can pick up pretty quickly and deploy in practice. And this has really been seen over the last year as it's kind of rolled out across the country. It looks like it's something that can help us improve throughput in terms of BPH care and surgical volume.
Wow. So I would guess this, like thinking about it mechanistically, like or mechanically, is that the better word to say? Like, why would there be such a difference with the hot water steam vapor versus the water itself? Like, in terms of like, why would there be that big of a difference?
Good question. So, the steam is killing the cells, waiting for apoptosis and sort of resorption of the tissue and everything. The water jet is literally a pressure washer.
Okay, so it's blasting
It's just
it out.
blasting the tissue out of there. Yeah.
Okay. Well, Dr. Gill and Dr. Shakti Mahin, thank you so much for your expertise. This has been wonderful. I've learned a ton, and I'm sure our audience learned quite a bit as well. Thanks for joining us.
Thanks for having us.
Yeah, thanks for the opportunity. It was great.
Yeah, thank you for your time.
Thank you for your insights in helping us to go beyond the pages of the Cleveland Clinic Journal of Medicine. To read CCJM articles, visit ccjm.org. To participate in other accredited educational activities, visit ccfcme.org. You can subscribe to the podcast on Google Play, Spotify, or however you prefer to access your podcasts.